flexible during labor to allow the smallest diameter of that head to come out through the birth canal. And you will notice that once the child is born, the head is kind of upward because of that molding. The more difficult the level or the process of that molding taking place, the more impact or the more pressing, the more pressure it puts on that cranial bone and the cranial and the brain structure. And if it is too severe, that may put too much of pressure in that developing brain, and that could lead to a permanent problem in that brain. One instance would be when you have a severe case of fetal hypoxia, whereby there is diminished oxygen. And as you know, the brain has a very high affinity for oxygen. So that singular assault on that brain may lead to deformity or problem, as you will see in the case of cerebral palsy and other things that could happen in the child. It could be due to an error when you do, if they still, when most of the OB physicians would, rather not do that anymore. Forceps delivery, and you apply the forceps incorrectly, crack the skull, injure the brain, that can result to a neuro problem in that child. Okay, so once that happens, another thing is that the spinal cord also is, the child is still developing, they are not ready to hold their head and all that. So any little thing that causes that severance of that spinal cord during that can lead to spinal cord injury. It will also be due to accidental fall or anything that happens to the child. One thing that we notice is that some of the kids that are abused with shaky baby syndrome, so that feel that you bounce their brain and their spinal cord so much against the floor that can lead to permanent injury also. And a lot of these kids, we see them also in children with life support. So it could be from birth, it could be due to acquired problems. So either way, this is where we would like to focus on anything that can lead to injury. Another thing in pediatrics is that when we talk about growth and development, okay, all the structures are immature, and as the child grows, they will, development will occur. One of such would be their myelin tissue that covers the spinal cord. Prior to the full coverage of the spinal cord with myelin tissue, actions are all involuntary. So the myelination of that spinal cord is incomplete, and as the child grows and as they acquire more myelin tissue, they start to acquire more purposeful actions. And one of those would be the ability to control their ball and dagger. So prior to age 18 months, when it's still not too fully acquired a myelin tissue, that child may not be able to have achieved a full ball and bladder. However, some would, like we said, that the growth and development is flexible, will have that time frame, that it will happen. parents will be able to train their kids earlier in a younger age that they will make it like okay every 2 hours 2 to 3 hours I will have to um, you know force you to go to the bathroom make make you to go and by so doing over time it becomes a habit for that child. Not necessarily that the child was able to achieve that purposefully on their own. So the same you would look at that way for a patient who has spinal cord injury, you train the bladder, meaning you can do two things. One, if the patient has an indwelling catheter, Foley catheter, they can clamp the catheter, and every 2 to 3 hours you release it and the patient will fall. Over time, that patient will achieve a period of dryness within those 2 hours, and then towards the third hour, they will have to, they will achieve the wet diet. So they're able to empty their bladder like that. Or you straight cut them every 2 3 hours, and that way they still achieve that period of dryness. So now this is not to say that that person who has that spinal cord injury is able to control their bladder because they don't have the ability anymore. However, you train that person to do that. Okay, so that person is trained by clamping and releasing that of doing intermediate catheterization in between. Okay. So another thing you will notice is that with the reflexes, you have all the reflexes in the immediate newborn, and then they will start to diminish as the child grows. So one thing you will note that any child, anytime you see hypertrophy or hypo, increase in muscle tone or decrease in muscle tone in a child, that is an abnormality. It's not normal. What are the reflexes that you elicit for in your newborn assessment? Okay. The moral. Startling reflex. Okay, which one? Moral reflex. Okay. Of all these, which ones persist throughout life? None of them? Huh? None of them? Okay. Your gag, how about your gag reflex? Does your moral reflex persist for life? What is moral reflex? Okay. So does it persist for life? No. How about the Babinski? What is the Babinski? What is the Babinski? So what happens to the Babinski? Okay, does it persist for life? No. It's an abnormal if you see it. Beyond the what's happening. When does it disappear? If you see beyond 6 months, that's an abnormal reflex. Okay. All right. So some of the conditions, some of the factors that can affect our neural problem will be that can predispose a child or a person to neuro problem will include prematurity. The younger that fetus, or the more premature that fetus, the baby, the infant is, the more likelihood of having some form of neuro problem. Difficulty in birth, I just explained it with that, it's so severe of a molding that can cause too much of a pressure in the cerebral vessels, the tissues and vessels. Infection during pregnancy, severe headaches or anything that can cause an increase in intracranial pressure, alteration in gait, fall, hitting the head, or any visual disturbances, or even head injury or trauma. Some of the things that we would like to do in terms of diagnostic tests would include lumbar puncture or spinal tap. Of course, we'll do that to what will we look for in the spinal tap? What are we getting? Spinal fluid. Okay, and we're looking at the cell count. We're looking at if there is any infection. We're looking at the pressure. We're looking at the color of that to see if there is any problem with that. They can do a head and neck X-ray, the EEG, and they can do one spot EEG as you would do like your EKG on screen, or they can do a video EEG over a period of time, 24 hours, 12 hours, 48 hours, 22 hours, or depending on what the physician is looking. They can do a short term, they can do a long term. They can do a CT scan or MRI. Or sometimes they will do the PET test, which is very similar to your CT scan. Or they can measure the intracranial pressure. This more often will be the intensive care unit that they will do that measuring, or do their ultrasound or cerebral angio. Medications that we use commonly will include, depending on what the problem is, we can use antibiotics or anticonvulsants or analgesic or osmotic diuretics or corticosteroids. Again, this will depend on what we are trying to treat, and as we go to those disease entities, we will the medications in which one we are using. Common treatments would be to place a shunt. This we will use when there is a problem with the flow of the cerebrospinal fluid. So we would like to re-establish that flow, and the physician will insert a shunt from the ventricle, and then we'll attach it to the peritoneum. And that will be the first place they will go to, and that's how it got its name, VP shunt, ventricular peritoneal shunt. This is not to say that they cannot insert the shunt anywhere else. They can put it anywhere else, or they can even externalize the shunt depending on what is going on with the patient. But this will go in details when we do the hydro. They can ventilate the patient, put a trach and vent, especially when they have a high cervical injury that affects the respiratory centers, and they are not able to maintain their airway. They can do a PT, OT, and speech therapy. or they can do a vagal nerve stimulator or ketogenic diet that we will use in um, seizure disorder, which we'll treat later on. So, as you know, to take care of a patient who have a neuro problem, or we suspect that we have a neuro that has a neuro problem, we will start again with history taking. So in other words, you cannot plan or you cannot take care of any person without getting a little bit of history from that person. And the history we are looking to take, we want to get a comprehensive history. We want history of the pregnancy and family history. Why would we want to look at the pregnancy history of the for the child, pregnancy history, prenatal history for the child? Why would we want to do that?
See if there were any complications.
Okay. If there was any complication during pregnancy, pre, intra, and postpartum period. So we would like to measure the height and weight, head circumference. Why head circumference?
Head circumference represents the how well neurological development is. You can measure, but based on the size of the head circumference, you can see whether the child is being developed neurologically up into different pounds.
Yes, you can tell by the differences in size. Remember when we got the baby, we measured the baseline and we were able to compare the differences between the baseline head circumference and the next time the child presents to us. So you would like to know, is this, even if you are seeing the child for the first time and you measure that, is this really appropriate for the age? So that you kind of put it, this child is this age. For a child like this, the head circumference should be something like this. Now, is it appropriate for that child when you put it on the growth track? So you like to know if there is any problem. The head can be too small, the head can be too large, or even without measuring, sometimes you see, you notice that something is really wrong. And then you put your measurement tape and you see, oh, okay, quite different, below or above. And you'll also like to know the developmental milestones, what the child is able to do for each age. And all this, you would like to kind of get that information. What time was the child able to sit, hold their head, what activities does the child do normally? Is this normal for the child that the child sleeps all the time, or what is the sleep pattern? Okay, something like that information you would like to gather from the parents. Okay, and also you would like to look at the eyes. You like to look at the level response to light. You like to examine that, check the cranial nerves, do a motor function, which when you look at the tone of the muscle. Okay, and also look at the sensory muscles, and this is when you look at those reflexes that you were able to elicit during the newborn, and then if it's still persisting, then there may be a problem. Look at the child's coordination. Okay, and in fact, you're just assessing what they should be doing normally for their age. Okay, and then for the school age children, you look at their mental status. How do they behave in school? What is their school record like? So that should be part of your assessment. Again, other things would be level of consciousness. If that person is awake and appropriate for their age, do they interact with the environment, or they are awake but cannot interact? The child cannot smile. The child cannot recognize any familiar figures, or the child is just static. Sometimes the child person may be confused or disoriented sometimes, or they are awake but very weak, very lethargic. Okay, so you need to kind of look at their level of consciousness, and that's how you will note that there is a problem in that in the child. Okay, so any questions with the level of consciousness for the child, or things that you will want to check for a child that is that you suspect has a problem with neuro. Okay. So other things that would have the problem would be anything that can cause an increase in that child's pressure in the head. And with that increase in intracranial pressure, we'll say that it is anything that has an increase of more than or equal to 10 millimeters of mercury. Anything that can cause an increase in the brain size. It could be increased from cerebrospinal fluid due to accumulation. It's not draining the way it should. There is a backlog somehow. Or it could be as a result of an injury, and there is accumulation of blood in that head. So for anything that causes that increase, that could be that can affect the child's functioning. Note that during cry, when a child cries, there is a slight increase in the intracranial pressure. Okay. And over, with that, the body will compensate for it, and it's not, a problem. However, when there is persistent increase in that pressure, then there is a problem. Okay. So sometimes you smile, so you laugh so hard, you increase that intracranial pressure, and you start even to hear sometimes. Okay, so as long as you're able to, the body is able to compensate for that increase and goes back to the baseline, that's fine. But when it doesn't, then that is the problem. Okay, because with that increase of persistent increase or sustainment of that pressure, it could lead to deprivation of oxygen and nutrients to the brain. Example also with your OB, you have fetal hypoxia. There is less oxygen going to the fetal at that time. Okay, if that is corrected promptly, you don't have a permanent, result in the neural system. However, if it is not corrected and it's prolonged, then of course you have a permanent. You may have a permanent damage on the person. And some of the early things that you will notice will be certain slight alteration in that person's mental alertness. Person can start to become very irritable, and then over time, depending on the area of the brain that has the problem, then you may start seeing impairment in judgment and memory. So, with increase in intracranial pressure, we have the early signs that we can look for because there is you know the you know any manifestations in a child will include that child can become very irritable and restless. Child can vomit or have difficulty feeding. You can start seeing like a bulge in their fontanelle, especially the anterior fontanelle. When you measure their head circumference, you see that it's slightly increased. For a younger infant, you notice that the suture lines are kind of widened. And further, you can see that the veins on the scalp, you see them, they are slightly distended. Or depending on that level, on the severity of that pressure, they can be very, very distended. Other things that you will see is that because of that pressure on the vital centers of the head, of the stuff, you see that there is an increase in temperature. But you may see a decrease in respiration. And on the other hand, if you see an increase in blood pressure, that would also be, you see also a corresponding decrease in the pulse rate. For an older child, you will notice alteration in level of consciousness in the child. Child would actually complain of having headache because the body, once there is an increase in pressure anywhere, the body will just refer to it as pain. Nausea and vomiting also. They can have difficulty focusing, especially in bright light. Some of the
Sorry, why is the nausea and vomiting in the morning? Why is the nausea and vomiting in the morning as opposed to like later on?
most of the time when they sleep in the morning, they're just waking up, and then the whole there is when you are in a state of sleep, there is stasis because there is no activity at that particular time. So there is more increase in that pressure in the head at the time. Okay? But in the morning they will make due to that more increase in pressure at that particular time. So they will see that. But again, depending on how severe it is over time, that will be one of the things that we will always notice. Now, as the condition progresses, once we start seeing something like bradycardia, decrease in level of consciousness, or decrease in command, or response to command, or decrease in painful stimulus, then that is really like a very late sign. Okay? You start at that time. You start seeing irregularity in the patient's respiration. And the person can even get into coma and die. So our strategy would be to identify the problem on time and intervene. One thing we would like to do is to relieve that pressure, and one of the things we would like to do is to position the patient head up, prop the head up. We would like to avoid activities that may further increase the pressure in the head, meaning things that can cause the child to cry, or anything that can, put in some discomforting thing, or will putting the head of the bed down, thereby increasing the flow in the head. So we would like to raise the head. We would like to eliminate noise, environmental stimuli. This will be a child that you have to put at the corner of the unit. And we would like to offer good nutrition, but being very careful not to overhydrate the child. Eventually, they decide to do a tube feeding, to be NG tube or G tube or whatever. Just be very cautious about aspiration. Precaution should be something that you have to be mindful of. So that the increase in intracranial pressure can result from anything. It could be from trauma, it could be from infection, it could be anything that can cause that. So if you are able to treat or to deal with preventing further increase in that pressure in the skull, that would be an ideal thing to do. So specifically, some of the things that can lead to that increase in intracranial pressure would be a head injury. And head injury can be from fall, it will be from accident. Now that we are getting towards the summer months, bicycle injury, especially when they do not ride their bicycles with helmets. So one thing we need to emphasize as part of preventive measure would be to for the child to wear proper fitting helmet, not just any helmet. It has to be properly, not the helmet they wore as a 2-year-old and then they are 10, they're still wearing that helmet. No. So it has to be properly fitted with all the latches that they put in. Another thing would be fall from the crib. And injuries, other injuries. So what is happening is that there's force of the one that is that impact on the skull. So it can lead to injury in the head, in the structures, and with that you have some lasting injuries which can be as false skull fractures, or it could be contusion, or it can lead to bleeding, or hypoxia we talked about as in intrauterine hypoxia, or infection, or that can lead to or cerebral edema. So these are some of the things that can lead to primary head injury. So the infections, we're looking at infections here that can cause injuries. Some of those we know that once there is an inflammation in the cerebral tissues or the meninges, it can lead to inflammatory process. With that inflammation, there is a swelling, and we're looking at things like bacterial meningitis, or Raynaud's syndrome, or encephalitis, okay, or aseptic meningitis, meaning the viral meningitis. Okay, so all these things lead to inflammation in the brain structure. So the bacterial meningitis, for instance, is an acute inflammation. It's caused by strep, pneumonia, or B. hemolytic streptococcus, or E. coli. And their mode of transmission is by droplet infection. And once the organism gets into the cerebral tissues, it kind of spread through their cerebrospinal fluid. So with that, that's one of those causes of infection, and the person needs to be, once you identify the patient, you need to isolate that patient. And that's one of the reasons why you hear a lot of, once there is an outbreak of meningitis or suspect of meningitis, or a child was identified as having meningitis, everybody is panicking because of the severity of the problem. So how do we diagnose this? We'll have to do a lumbar puncture to identify the causative organisms, and we can do a blood culture or do a throat and nasal culture, especially if the cerebrospinal fluid is negative. And then you have to give IV antibiotics. Once you start the IV antibiotics, you put the patient, once you get the specimen, you put the patient in isolation and infuse the antibiotics until you get your results. If you get your preliminary results and after 24 hours on IV antibiotics, you can take the person off isolation. So we would like to monitor the patient. We will have to have our emergency airway at the bedside, and we want to minimize anything that can cause increase in intracranial pressure. What we are doing also will be to treat the symptoms, which is fever, and would like to monitor for other complications such as seizure or that can happen in the child. for your patient that has that head injury, um, you would like to monitor that child very closely. You will want to watch the child for at least 6 hours for any vomiting, any change in level of consciousness, if that child falls asleep, the child falls asleep, normally they would. You would like to arouse or wake up the child every hour or every 2 hours at least to check their level of consciousness. Within that time you are observing that child, you do not want to give any sedative, anything that can make the child sleepy. And you would like to also watch disciplinary reaction. Disciplinary reaction for life and accommodation every 4 hours, at least for the first 48 hours. But for the first 6 hours, you must observe that child very closely. And if anything happens, just take the child to the ER. And in the ER also, they would like to keep the child and observe the child as well. So other forms of meningitis could be the non-bacterial one. And this is the one that we said is a virus. But we wouldn't know whether it's a virus or it's not when the child first presents to us. So we treat all cases of meningitis as if they are bacterial in origin, and that's why we isolate the person until proven otherwise. Other things that can cause non-bacterial meningitis could include their remember when we talked about leukemia, we said that some of the leukemic cells can go to the cerebral tissue and lodge themselves there, and that will just be their own hideout. Okay. So that can cause an irritation in the meninges, and which will lead to that inflammation. So this is very, very gradual in onset. So the person may manifest as having that headache because of that increase in pressure, and the person may have fever and just feel ill. Until you look at the cerebrospinal fluid, you'll be able to say, yes, this or this is up there in the brain. Other than that, you just treat it as non-specific thing that can happen in any other disease entity. Okay. So the treatment, of course, you treat it as bacterial meningitis, do all the blood work and spinal tap and blood work, and then you start your treatment, but focusing on the symptoms that the patient is presenting. Prognosis is usually very good if treatment is used for the you would like to reduce the fever, reduce pain, but in the case of the leukemic cells, just use the intrathecal chemotherapy to take care of that, and just your goal is to reduce that and make sure that you do not increase the intracranial pressure by all the nursing actions that you will put in place. Another neuro disorder I'll just give you some specific would be the Rett syndrome, and this is one thing that will already recognize that we associate with the use of aspirin in children. So it's when there is that toxic inflammation or encephalopathy that occurs in the brain. With that, the child will have severe fever, and there is very decreased level of consciousness, and there is also a dysfunction of the liver or the hepatic system. This most of the time will follow a viral illness, and it's been associated with aspirin. So the problem you get is the person will have fever, they have decreased level of consciousness, and they will have dysfunction of the liver. The etiology is really unclear. However, it's been associated with viral infection plus ingestion of aspirin. So with that exposure, the toxin will go to the liver and damage the liver cells. With that damage of the liver cells, there is dysfunction in the liver, and the liver will not be able to function effectively. There is increase in ammonium level, which causes a dysfunction in the cerebral tissue, resulting in fluid retention. And because the liver cells are damaged, it affects the ability to function and to coagulate blood, because the liver is the chief organ that is involved in blood coagulation. If the liver is not functioning, then everything that has to do with that cascade is not functioning well. So again, the diagnosis here is done by liver biopsy. And then some of the symptoms that you'll notice will be the child will vomit, there is changes in mental status, the child is very irritable, confused, and child has hyperreflexia. Management will be this child is admitted to the people, admit the child into the intensive care unit, and you would like to monitor the neural status of the child. Due to that alteration in the electrolytes and the liver function, we would like to hydrate the child and monitor and replace the acid-base balance, electrolytes. some of the medications because the ammonia level increases the irritation and swelling in the brain. You would like to give some medication like osmotic diuretic that will reduce the swelling in the brain, and also once the swelling is reduced, it will decrease the intracranial pressure. Okay. Another thing that will happen, you would like to, because of that alteration in that level of in the brain, you will likely have seizures. So they would like to give dilantin as a preventive and treatment that you will use for the to control seizure activity and to help the liver with the coagulation of blood. You would like to give vitamin K. So that will be your strategy there to take care of that child. Prognosis is usually fine if you support this child very well. If the child is especially if the child is supported very well, they have a good prognosis. However, if it is a very advanced stage, in stage 4, when you have so much damage to the cerebral and the liver cells, then the child will, most of them usually succumb to their disease. So again, our strategy is early identification of those early times, but when it's very, very advanced stage, then the child will not make it because they cannot function with that. So we would like to monitor the child's physical status. We would like to monitor the cerebral and reduce the cerebral edema. Monitor the intake and output. And we would like to continue with our neuro assessment in order to identify changes in that neuro status. I would like to support the family as much as possible. Because this child is just well this minute and then the next minute due to the viral infection, the whole thing starts and then the child is deteriorating as fast as the things started. So any questions?
Regarding the Reye syndrome. You were mentioning that aspirin was associated with that. Can you explain that?
Well, research documented that giving aspirin to children with viral illness can predispose the child to neuro dysfunction that will form this cascade of Reye syndrome. And because of that, aspirin is contraindicated when the child has a viral infection. However, in pediatrics, we have two conditions where we give aspirin, and that's when we have to weigh the benefit of giving the aspirin to treat those two conditions, Kawasaki and rheumatic fever, as opposed to developing the Reye syndrome. So in that instance, if a child is getting aspirin to treat those two conditions, that child will have to be monitored very closely in response to this developing the Reye syndrome. However, Reye syndrome has been associated with viral infection. But Kawasaki is not really a viral infection. But aspirin, the link of aspirin to it is what causes that. Any other question? Yeah. Catherine. Any other question? All right, I think we can take